You are welcome, our dear students. Today we are going to talk about conditions of the cardiovascular system. Yeah, and the cardiovascular system basically comprises of the heart, the blood vessels, and the lymphatics. Now, today we are going to basically talk about the conditions of the arteries. Yeah. In other words, the conditions of the blood vessels. So specifically today, we shall talk about hypertension. So what is hypertension, if I may ask? Yeah. So if you could briefly ponder and then maybe think about the answer, while I should mention that increased pressure within the systemic vascular system, yeah, is what we refer to as hypertension, yeah. And you should know that hypertension, of course, comes from blood pressure, and you should know that blood pressure is actually a product of cardiac output times the systemic vascular resistance. Cardiac output times the total peripheral resistance or systemic vascular resistance. Now, blood pressure is basically determined by that. And you might want to ask yourself, what is cardiac output? Now, cardiac output is the amount of blood that is pumped out of the heart chambers on the left and on the right in 1 minute, yeah? And this cardiac output is also determined by what we call the stroke volume and the heart rate. So in other words, we are saying that cardiac output is also determined by the stroke volume times the heart rate. So we are saying that if cardiac output increases, yeah, then keeping all other factors constant, then the blood pressure will also increase. At the same time, if the total peripheral resistance increases, then the blood pressure will also increase. And we are saying here that if the heart rate increases, then the cardiac output will also increase. So we are going to see that the factors that actually affect cardiac output are things like blood volume and heart rate. Now, what factors influence blood pressure? We've talked about some of these. We are saying that the heart rate is one of them. The effect of the autonomic nervous system. The effects of the autonomic nervous system, or what we call the sympathetic nervous system, and the parasympathetic nervous system, yeah? So the effect of these two systems influences the blood pressure of an individual. So things like vasodilatation or even vasoconstriction, these influence the blood pressure of an individual. Remember, we talked about total peripheral resistance. Now, if a blood vessel constricts, then that basically means that the total peripheral resistance within the arterial system increases. At the same time, if it dilates, then the total peripheral resistance reduces. Now, the other thing that is very important as far as influence of blood pressure is concerned is blood volume. In other words, the amount of blood that is within the vascular system. And of course, we said that the blood volume directly influences the cardiac output, which in turn influences the blood pressure. Now, blood volume is regulated by systems. We have what we call the RAS, yeah? We have what we call the RAS, the renin, angiotensin, aldosterone system. Now, we shall look at that. The RAS, the renin, angiotensin, aldosterone system, is one of the mechanisms that is put in place by the normal body, by the body, as far as regulation of blood volume. But we also have hormones like aldosterone. Now, this one is secreted by the adrenal glands, yeah, specifically the adrenal cortex. And then we have hormones like the ADH, or the antidiuretic hormone, which is basically secreted by the hypothalamus and is stored in the posterior pituitary gland. Now, all these factors play parts as far as influencing blood pressure is concerned. Now, take a closer look at that picture. Please take a closer look at that picture. That picture is basically telling us that, you know, what basically determines the systolic blood pressure and what determines the diastolic blood pressure. You know, blood pressure is basically measured by two figures. There's what we call the diastolic figure, and there's what we call the systolic figure. Now, two figures, yeah? So in other words, we are saying the systolic figure over the diastolic figure. The diastolic figure. So that is how blood pressure is basically denoted. Now, what influences the systolic and what influences the diastolic figure of blood pressure? Now, this diagram basically explains it all. Now, according to that diagram, it is basically demonstrating that you have the heart, assuming this is the left part of the heart, yeah? And then this is the left part of the heart, and then these are the arterioles, yeah? The arterioles of, these are the arterioles, yeah? This is the left, strictly we're taking an example, yeah? This is the left part of the heart. Of course, then these ones would be your, these would be your aortic valves, yeah? And of course, this one would be your mitral, this one would be your mitral valve. Now, assuming that blood has entered from the atria. Now, we are assuming this is the left atria, yeah? Left atria, and then the left ventricle, yeah? Now, assuming blood comes from the left atria, yeah? And then it fills the left ventricle at the what we call the end diastolic, at the end diastole. What actually happens is that now the ventricles, and we are talking about specifically the left, it is ready to contract, yeah? So if it contracts, if the left ventricle contracts, what actually happens is that as it contracts, the aortic valves have to open, yeah? So the aortic valve opens, the aortic valves open to allow blood, yeah? To allow blood to go to the you know, the aorta. So assuming this is the aorta, and these are the arterioles, the different arterioles. Now, the aortic valves open, yeah, so that blood is able to move, yeah, to the aorta, yeah. Now, the amount of blood, the pressure with which the left ventricle pumps the blood, yeah, is basically transmitted across, yeah. The same pressure here, yeah, is the same pressure transmitted across the artery, the aorta, yeah. And of course the the pressure with which the left artery, the left ventricle contracts is basically dependent on the end diastolic volume, yeah, depending on with respect to what we call the Frank-Starling law, yeah. Now, so the pressure with which the left ventricle contracts is the same pressure with which it will transmit, yeah, it will, with which the blood will be transmitted across the aorta. And usually the pressure with which the left ventricle contracts is usually 120, yeah? The mean is usually 120 millimeters of mercury. Now that is the pressure with which the left ventricle contracts to push blood. Now this is you know, this is usually on average, this is usually the systolic blood pressure. In other words, we are saying that the systolic blood pressure is basically determined by the pressure by which the left ventricle pumps blood, yeah? And that pressure is usually 120. And it is determined by the feeling of this ventricle, which will eventually give us what we call the cardiac output. Now, after the ventricles have contracted to release blood into the aorta, what actually happens is that the aortic valves now close, yeah? So the aortic valves close completely in a normal human being. The aortic valves are supposed to close. And therefore, the blood that was pumped out basically it stays here. The blood that was pumped out basically stays on this other side of the valve. Now, what actually determines the systolic blood pressure is the total peripheral resistance. In other words, if these arterioles are dilated, then the blood will flow easily, yeah? Will flow easily to other, you know, target structures or organs. But if these arterioles are constricted, yeah, then the blood will not flow easily across the arterioles because of the constriction. And basically the pressure which is around here, is what we refer to as the diastolic pressure. So the point to take home here is that the cardiac output determines the systolic part of blood pressure, while the total peripheral resistance determines the diastolic part of blood pressure. That is the point to take home. Now, assuming you have understood that, there is something else that I want you to be able to interpret, and that is what is in the next diagram. Now, you see in that diagram, assuming you have a drug, and those drugs basically change either the systolic or the diastolic blood pressure. Just imagine, assuming you have this curve, assuming you have this graph, assuming you have a graph like that, and then you have drugs, yeah? Assuming the 120 is our systolic blood pressure, and 80 is our diastolic, yeah? Assuming those are our diastolic and systolic blood pressures, respectively. Now, if I give a drug A, and that drug A increases the systolic blood pressure, it basically means that it increases the systolic blood pressure, but it maintains the diastolic blood pressure. So it basically means that this drug A, what has it actually done? This drug A basically increases the cardiac output. Yeah. Now, if I give again another example, if I give a drug, if I give a drug B, yeah, if I give a drug B and it reduces the systolic blood pressure, yeah, and it reduces the systolic blood pressure. So this drug B, basically what it means that it has basically decreased the cardiac output. Are we together? Now, the other example, if I give a drug C, yeah, if I give a drug C and that drug C does this, yeah, I give a drug C and that drug C does that, yeah. So what has that drug C done? Yeah, that drug C has basically, so if this is our drug C, if that is our drug C, what has it done? It has basically increased, it has increased the systolic blood pressure, yeah? So what does that mean? It means it has increased the total peripheral resistance, yeah? But on the other hand, it has had no effect on assuming that drug has no effect, yeah? Assuming it is like this, therefore it has had no effect on the systolic blood pressure, yeah? Now, if I give another drug D, yeah? If I give another drug D, and that other drug D, what it does, it basically, if it does something like this, yeah? If it does something like this, yeah? And then it does something like this as well. So what does that mean? It means that that drug has increased the total peripheral resistance, yeah? But at the same time, it has decreased the cardiac output. Now, that is how drugs usually work, especially on the heart, yeah? They basically play around with either the cardiac output or the total peripheral resistance, yeah, of the blood vessels, yeah? Now, so this point is very, very critical as far as the different drugs that are used with management of hypertension are concerned, yeah? So what we have just been seeing, we have been seeing the effect of drugs on either the cardiac output or the total peripheral resistance. Now, we looked at factors that basically influence blood pressure, yeah? Factors that influence blood pressure, and we said that one of the factors that influence blood pressure is basically, cardiac output, which in turn is influenced by things like total blood volume, yeah? So the blood volume, and all factors that increase the blood volume basically will increase the blood pressure, yeah? Things like sodium intake. What does sodium intake do? Sodium intake, well, so when you increase the intake of sodium in the body, what it actually does is that where sodium goes, water follows, yeah? In other words, where sodium goes, water follows. And as a result, if you take sodium, then therefore you even have plenty of water within the bloodstream. So we also have conditions like hyperaldosteronism. Now, aldosterone is supposed to cause absorption of sodium, yeah, in the within the nephron, yeah. And as a result, if sodium is absorbed, then the water will follow, yeah. Things like heart rate and contractility, yeah. Remember, we said that the cardiac output is influenced by heart rate. So therefore, if the heart rate influences cardiac output, therefore, it will also influence the blood pressure, yeah? And also things like contractility of the blood vessels, all these influence blood pressure. Things like, now for the total peripheral resistance, things like humoral factors, yeah? Like for example, the angiotensin 2, yeah? Which is a potent vasoconstrictor, yeah? This one also influences the total peripheral resistance, which will in turn influence the blood volume. Now, we also have catecholamines, things like epinephrine, which is basically released by the adrenomedulla, yeah? It will also influence the blood pressure. Things like norepinephrine, dopamine, all these are catecholamines that are basically secreted and they influence the blood pressure. On the other hand, we have chemicals that are also released that basically cause dilatation of the blood vessels, and as a result will basically cause a reduction in blood pressure. Now these are things like nitric oxide, yeah, nitric oxide, yeah, NO, things like prostaglandins, things like bradykinin, all these are basically vasodilators, and as a result, they influence the total peripheral resistance, which will in turn influence the blood pressure. Now, let's briefly talk about the effect of the renin, angiotensin, aldosterone system. Now, I'm going to request you to read about it further, please. Yeah, I'm going to request you to read about it further. But what it basically entails, what the renin angiotensin aldosterone system entails, within the kidneys, yeah, within the kidneys, we have structures that are referred to as the juxtaglomerular apparatus, yeah? The juxtaglomerular apparatus. Now, these juxtaglomerular apparatus are the ones that are responsible for secretion or production of urine, renin rather. Now, what actually happens is that when there is low blood flow, yeah, within or when there is a low glomerular filtrate, yeah, within the nephron, what actually happens is that the juxtaglomerular apparatus are stimulated to produce renin. Now, renin is a hormone which is produced by the juxtaglomerular apparatus within the kidneys, yeah, within the nephron of the kidneys. Now, these ones, we said they secrete renin, yeah, which is a hormone. Now, when renin is secreted, yeah, it basically causes the conversion of angiotensinogen to angiotensin 1, yeah? Now, this angiotensinogen is basically in the liver, yeah? So renin causes conversion of angiotensinogen, yeah? Renin, we are saying that renin causes conversion of angiotensinogen it causes conversion of angiotensinogen to angiotensin 1. Angiotensin 1. Now, this angiotensin 1 basically freely circulates in blood, yeah? Now, as it circulates in blood, what actually happens is that within the lungs, yeah, within the lungs, we have an enzyme called angiotensin converting enzyme, yeah? So within the lungs, we have an enzyme called angiotensin converting enzyme. Now, this angiotensin converting enzyme, yeah, what also referred to as SCE, angiotensin converting enzyme. Yeah? Now, this angiotensin converting enzyme causes conversion of angiotensin 1 to angiotensin 2. Yeah? So it causes conversion of angiotensin 1 to angiotensin 2. Now, this angiotensin 2 is a very potent vasoconstrictor. In other words, it causes vasoconstriction. Now, not only does it cause vasoconstriction, but it also causes release of aldosterone from the adrenal cortex. Yeah, and because it is a vasoconstrictor, what actually happens is that there will be, there will be increase in, there will be total peripheral resistance will increase, and as a result, blood pressure will increase. But also, it causes it causes secretion of aldosterone from the adrenal cortex, yeah, which aldosterone will work in the nephrons to cause absorption of sodium and in turn water, yeah, and as a result will cause or will bring about an increase in blood pressure. Now, that is how the renin-angiotensin-aldosterone system works. In other words, it basically helps to raise the blood pressure. Yeah, it basically helps in the raising of blood pressure by the mechanisms that we have basically talked about. Now, I want you to read more about it, the renin-angiotensin-aldosterone system. Now, let's talk about hypertension, our topic for today. Now, how do we define hypertension? Now, it is very important to define hypertension as a sustained elevation in blood pressure in the systemic arterial circulation. Now, it is very important for you to stress the word systemic arterial circulation, because we have increased blood pressure elsewhere. Like, for example, it can be portal hypertension, but that is not the hypertension we are talking about here. The hypertension that we are talking about here is what we call the systemic arterial hypertension. Yeah. So the definition is that it is sustained elevation of blood pressure in the systemic arterial circulation. Now, the blood pressure, once it increases above, more than, if the systolic blood pressure increases more than 140 millimeters of mercury, then it is said to be systolic hypertension. Yeah. And then if the blood pressure of the diastolic exceeds 90 millimeters of mercury, yeah. In other words, if the diastolic pressure exceeds 90 millimeters of mercury, then it is said to be diastolic hypertension. Yeah. If the systolic exceeds 140 millimeters of mercury, then it is said to be systolic hypertension. Now, you would be asking, why those figures? Why those figures are not any other figures? Now, the reason is that studies have been done, and people who have been shown to have these figures are at an increased risk of cardiovascular diseases. Diseases like ischemic heart attack, diseases like myocardial infarction, diseases like stroke. Yeah, people with such figures are considered to be at an increased risk. That is why the cutoff is around those figures and not any other figures. Now, let us look at the classification of blood pressure. Now, blood pressure is basically classified into those 4 types, as you can see. Yeah, there is what we call the normal blood pressure. Yeah, the normal blood pressure, normal, and that normal blood pressure has a systolic of less than less than 120, yeah, a systolic, yeah, and then it has a diastolic of less than 80 millimeters of mercury, yeah. Now, the other one is what we call pre-hypertension. Now, the word pre basically means before, yeah, before hypertension. In other words, such a patient with pre-hypertension does not actually have hypertension, yeah? They don't have hypertension. However, they need maybe, a lifestyle modification, they need to be educated so that their blood pressure does not go beyond, it doesn't exceed, those figures. Now, a patient with pre-hypertension has a systolic blood pressure of between 180 to 139, yeah? A systolic blood pressure of 180 to 139, or, or a diastolic blood pressure of 80 to 89, yeah? So, or a systolic blood pressure of 80 to 89. In other words, we are saying that someone can have either an increased systolic of between 120 to 139, yeah, and then they are referred to as pre-hypertension, or they can have a systolic of between 80 to 89, even if the systolic is normal, yeah, even if the systolic is normal, but the diastolic is between 80 to 89, then they are referred to as pre-hypertensive. Now, the other stage of hypertension is what we refer to as stage 1 hypertension, yeah? Stage 1 hypertension. Now, in stage 1 hypertension, the blood pressure is between 140 to 159, yeah? 140 to 159, or 90 to 99 of the diastolic, or 90 to 99, yeah? 90 to 99 of the diastolic. Then we have stage 2 of, stage 2 hypertension, whereby the systolic is greater than 160, greater or equal to 160, and a diastolic of greater or equal to 100. Now, it is very important for you to know that a patient can come with such a blood pressure. Now, I'm going to ask you to classify that patient, which stage that patient falls, please. Now, assuming a patient has this kind of blood pressure, and maybe I should mention that with hypertension, you don't just take one kind of blood pressure and you basically diagnose this patient to be hypertensive. No, you basically take readings over time, yeah, for over time, and if they are sustained and elevated, then the person is said to be hypertensive. Now, I want you to tell me which stage this patient is. A patient has a blood pressure of 160 over a blood pressure of 89, yeah? So which stage is this patient? Can you please reflect on that? Now, you should look at the two figures, yeah? This is the systolic figure and this is the diastolic figure, right? Now, we are saying that this person's systolic figure, yeah, is basically 160. Now, where would you place that person of 160, yeah? that person of 160 would be in, in hypertension, yeah, in stage 2 hypertension, yeah. So in other words, now this figure here, even if it is low, yeah, but the systolic, yeah, the systolic is basically high and belongs within stage 2 hypertension, yeah, then this patient is said to have stage 2 hypertension. In other words, they have a systolic blood pressure of 160, yeah, but the diastolic is normal, yeah, but the systolic is elevated and falls within the stage 2, yeah. So that is why we are saying it is either a diastolic of more or equal to 160, or a systolic of more or equal to 100, or even it can be both, yeah. So it can either be a high systolic or a high diastolic, or both. In other words, both of them are raised. All right. So I hope you have understood that concept of classification of blood pressure. Now, for persons above the age of 50, it is very important for you to know that the systolic blood pressure is more important, yeah, than the diastolic blood pressure, yeah. I repeat, of the two pressures, diastolic and systolic, the systolic blood pressure is more important, yeah. The systolic blood pressure is more important than the diastolic blood pressure, yeah, because the systolic blood pressure, as it's basically associated with a lot of cardiovascular risk factors, like for example the left ventricular hypertrophy, yeah. Remember, we said that the systolic blood pressure is determined by the cardiac output. And for that case, if the cardiac output is consistently too much, it basically means that the ventricles, yeah, will hypertrophy, yeah, trying to push this blood within the ventricles, yeah. Now, starting at 115 to 75, you know, the cardiovascular disease risk basically doubles, yeah, with each increment of 20 over 10 millimeters of mercury throughout any BP range. Now, that is very important, and you should know about it. Now, how do we classify hypertension? Hypertension is basically classified as primary, or it can be secondary. Now, primary hypertension, this is basically sustained elevation of blood pressure without an unknown cause, yeah? In other words, the cause is not known, but it is basically an interplay of genetic and environmental factors. And this is the commonest blood pressure, yeah? Rather, this is the commonest type of hypertension, yeah? Within or among people, yeah? And it is prevalent in, in 90 to 95% of all cases with hypertension. Now, the other one is what we refer to as the secondary blood pressure, yeah? Now, the secondary blood pressure, rather the secondary hypertension, this is the one which is, blood pressure is basically elevated, but because of a specific cause, yeah? Like, for example, someone can have maybe kidney disease. Someone can have maybe problems with the pituitary gland. Someone can have problems with the adrenal gland. Yeah. Now, secondary hypertension, basically, there is a specific cause that can be pointed to. And once you treat that cause, then you can treat the hypertension. Now, what factors basically contribute to secondary hypertension? We talk about things like coarctation of the aorta, yeah? Now, coarctation of the aorta, this is basically what we mean. We mean that if this is your right atria, this is your left heart, yeah? The aorta ideally is supposed to come like that, yeah? This is your aorta, yeah? This is your aorta, yeah? Now, with coarctation of the aorta, we mean that the aorta basically constricts, yeah? It constricts at that point, yeah? It constricts at that point, yeah? Something like that. Now, this is what we refer to as a coarctation of the aorta. In other words, the lumen reduces, yeah? The lumen of the aorta reduces, yeah? That is what we refer to as coarctation of the aorta. And as a result, the heart will find it very hard to pump blood, yeah? This ventricle will find it very hard to pump blood across that, that constricted or narrow lumen, yeah? And as a result, the patient will have what we refer to as hypertension. And in this case, it will be secondary, yeah? Things like renal disease, renal stenosis, conditions like glomerulonephritis, polycystic kidney diseases. Now, we shall look at these as we move on, yeah? Conditions like endocrine disorders, like acromegaly, hyperthyroidism, diabetes mellitus, things like hyperaldosteronism, all these are associated with increase in blood pressure, and in this particular case, it is basically secondary. Now, if you treat the underlying cause, then that basically means that you have treated the hypertension. Now, what are the risk factors for primary hypertension? Now, we said that for primary hypertension to occur, there should be an interplay of what we call genetic and environmental factors, yeah? So, for you to have primary hypertension, there's basically an interplay of these two factors, yeah? So if things like age, alcohol intake, things like cigarette smoking, diabetes, elevated serum lipids, excess intake of sodium, and things like gender, all these basically can be risk factors to primary hypertension. Familial diseases or familial history, body mass index, ethnicity, sedentary life, and socioeconomic status. So in other words, there is an interplay between genetic and environmental factors, but you cannot point to a specific cause. You cannot point to a specific cause, but there is an interplay between the genetic and the environmental factors that are bringing or are leading to hypertension. Now, we have already talked about these. Now, this is what I was saying. You know, you have an interplay between environmental and genetic factors, which bring about those factors, as you can see within the diagram, bringing about a sustained hypertension. And in this case, it is primary hypertension. Now, there's a condition which we call malignant hypertension. Yeah. Well, now this is basically an emergency. Yeah. So this is a condition that is basically characterized by diastolic pressure, which is greater than 140 millimeters of mercury. Now, that is very, very high. Yeah. It can cause encephalopathy. Yeah. Encephalopathy is basically, you know, pathologies within the brain matter. Yeah. So encephalopathy occurs because of high arterial pressure. Yeah. It renders the cerebral arterioles incapable of regulating, you know, blood flow within them. Yeah. And we also have an increased, you know, capillary permeability, as we demonstrated last time. And as a result, you have very high hydrostatic pressures. Yeah. And therefore, you'll have a lot of, you know, fluid seep out of the capillaries, creating edema, yeah? And the edema within the brain is what we call or refer to as cerebral edema. Now, of course, this will increase the intracranial pressure, and that is not a good thing, yeah? It is basically not a good thing. And it might lead to other things like papillary edema. It can even bring about cardiac failure and you know, things like retinopathies and even cerebrovascular accidents. In other words, the patient might get a hemorrhagic stroke. In other words, those arterioles might burst, yeah, and the patient gets a hemorrhagic stroke. Now, what are the clinical manifestations of hypertension? Usually, hypertension is referred to as a silent killer because in the initial stages, the patient is actually asymptomatic. Actually, some patients are actually not diagnosed, are undiagnosed, yeah, because they don't have the signs and symptoms, and for that case, they are therefore referred to as being asymptomatic. However, when it comes to end organ, you know, destruction, then they start being, you know, symptomatic, where you have things like fatigue, things like dizziness, things like palpitations, things like angina, things like dyspnea. Yeah, these are some of the, you know, the clinical manifestations of this. Now, it is also very important for you to know these are some of the structures that are basically damaged, yeah, as far as if this hypertension basically complicates, yeah. So within the myocardia, you can have, you know, left ventricular hypertrophy. Within the coronary arteries, you might have you know, myocardial ischemia, yeah. Within the kidneys, you might have things like retention of sodium and water, leading to increased, you know, blood volume, and then leading to perpetuation of, you know, hypertension, among others that you will read in this slide, please. Now, yeah, we've said that, you know, hypertension can also lead to things like you know, hypertrophy, yeah, hypertrophy of the, especially of the left ventricle, yeah. So the common complications of this hypertension basically are seen in the heart, yeah, they are seen in the brain, and they are seen in the eyes. Like, for example, in the eyes, you can have things like retinopathies, yeah. In the kidneys, you'll have things like, you know, things like sustained, you know, absorption of water is basically increased, leading to perpetuation of blood pressure. Within the brain, you can have, you know, what we've talked about, the malignant hypertension. And within the heart, you can have things like, you know, left ventricular hypertrophy, yeah? So things like hypertensive heart disease, coronary artery disease, left ventricular hypertrophy, and even eventual left heart failure, or even heart failure, as we shall see as we move on. All these might be complications of hypertension. And as you can see, that is basically the left ventricle. This is the left ventricle is basically hypertrophied. In other words, the lumen, yeah, the space for where blood has to fill is very, very, you know, small, yeah, because of this problem. Within the brain, we have things like cerebrovascular accidents, like, for example, stroke. We can have peripheral vascular diseases. We have nephrosclerosis, and then we can also have things like retinal damage, as we have mentioned earlier. Yeah. Now, how is hypertension diagnosed? Now, diagnosis requires, that is very important, requires several elevated readings, yeah, over several weeks. You do not just take one figure and then if it is high, yeah, then you conclude, yeah. However, if it is very high, yeah, more than 120 over 10, or rather over 110, yeah, then that is very high, yeah. However, for you to be able to diagnose hypertension, you must take several measurements of blood pressure over time, yeah. And if they are sustained, if it is sustained and high, then the patient is said to be diagnosed of hypertension. Now, I hope you know how to take blood pressure. Please revise how to take blood pressure. Now, blood pressure measurement should be done in both arms, and of course, you should always consider one which has a higher reading. Yeah, and diagnosis requires the measurement of blood pressure at least on 2 separate occasions. Yeah, averaging 2 readings at least 2 minutes apart, with the individual seated. Yeah, so the individual should be seated very well with the arm supported at heart level. Yeah, after 5 minutes of rest. Now, you don't want to immediately take the blood pressure of this person probably after walking or running. No, let them rest first. Yeah, then it should also be taken after like maybe 30 minutes of non-smoking or even taking caffeine, because we know that these things basically rise the blood pressure. Yeah, now some individuals, it is very hard, yeah, to basically diagnose blood pressure. And for that matter, we use what we call ambulatory blood pressure monitoring. Yeah. Now this is a machine that is basically tied in the region, maybe in the brachial region. Yeah. To basically and then the person goes home. Yeah. They basically do their stuff, they do their work, while that blood pressure machine is basically monitoring and recording the blood pressures. Yeah. Now that is very good, because it will help us with what we call the white coat hypertension. Yeah. In other words, when a patient comes to see a doctor or comes to see a health worker, then their blood pressure goes up. Yeah. Now it's very hard there then to diagnose hypertension. Yeah. So the good thing is to give them an ambulatory blood pressure monitoring cuff, yeah, or machine. Yeah. Then it also helps us with what we call masked hypertension. In other words, this is normal blood pressure in the clinic, yeah, but elevated elsewhere. In other words, when you come to the hospital or to the clinic, then you have a normal blood pressure. But when you go away, then it becomes elevated. So it helps us with what we call masked hypertension. Now, let's briefly talk about the goals of treatment of hypertension. Now, it is very important that the goal of treatment should be to reduce the blood pressure. Now, our goal is to reduce the blood pressure by at least less than 140/90, yeah, in patients who do not have any other comorbidities, yeah. But in patients who have renal diseases and diabetes, the blood pressure should basically be maintained, or our target should be to lower blood pressure less than 130/80. Now, what are the benefits of lowering blood pressure? The benefits of lowering blood pressure are basically, it reduces the incidence of stroke, it reduces the incidence of a myocardial infarction, and it greatly reduces the incidence of a heart failure by almost half. Now, below is basically a diagram that is basically trying to show us how we manage. Yeah. Now we manage blood pressure by giving drugs. Yeah, by giving drugs, and we have drugs like diuretics. You know, we have drugs like ACE inhibitors. Remember, we talked about ACE and ACE enzyme. Now, if you want to lower the blood pressure, then we want to give an ACE inhibitor. Yeah. So these are some of the drugs that are given. Now, when you do your pharmacology, you learn more on how these drugs, what these drugs are. Yeah, the beta blockers, among others. Now, this is the kind of like the algorithm for management of hypertension. Yeah. Other things, other collaborative modifications are things like weight reduction, dietary change. You know, there's what we call the DASH diet. Yeah, basically dietary. These are dietary measures that help us, to stop, hypertension. Yeah, dietary measures that are geared towards stopping hypertension. Yeah, things like limiting alcohol, you know, among others, as we are going to see. Yeah, so regular physical activity, avoidance of tobacco use, and then stress management. Yeah, now the DASH diets are basically dietary approaches to stop hypertension. Yeah, and these are things like you restrict sodium intake, get a diet that is rich of fruits and vegetables. Yeah, non-fat dietary products. Yeah, are also consumed, and then low calorific foods. Yeah, all these are basically geared towards stopping hypertension. We also have drug therapy, and remember we talked about basically drugs are geared towards either decreasing the, you know, the systolic or the total peripheral resistance, or even reducing the cardiac output. Yeah. So basically these drugs that are given are given with that in mind. They should either decrease the cardiac output, yeah, or decrease the total peripheral resistance, as we saw earlier in the diagram. So those are some of the drugs that are given when you do pharmacology. Then you'll be able to understand them. Yeah, thiazides, adrenergic inhibitors, beta blockers, SCE inhibitors, calcium channel blockers, you know, among others. Yeah. So patient teaching is very important. Yeah. Things like you minimize other side effects like orthostatic hypertension, which we shall talk about, sexual dysfunction, a dry mouth, frequent urination. These are some of the side effects that you should tell the patient to be aware about as they take the medication. Yeah. These are some of the nursing diagnoses, things like ineffective health maintenance, anxiety, sexual dysfunction, among and others. So that basically marks the end of what hypertension is. I hope you have understood the term hypertension and the pathophysiology behind hypertension. When we meet again, we shall talk about orthostatic hypotension. Thank you very much for being a good audience. Please read more where you have not understood, but also do not hesitate to contact me in case you have not understood some concepts. Thank you.